life, conscience, and bodily integrity. Prohibit abortion. Travel funding. Providing funding for abortions increases the number of abortions and violates the conscience and religious freedom rights of Americans who object to subsidizing the taking of life. The Hyde Amendment has long prohibited the use of HHS funds for elective abortions, but an August 2022 Biden executive order pressed the HHS secretary to use his authority under Section 1115 demonstrations to waive certain provisions of the law in order to use taxpayer funds to achieve the administration's goal of helping women to travel out of state to obtain abortions. Moreover, the Department of Justice Office of Legal Counsel, DOJ OLC, issued a politicized legal opinion declaring, for the first time in the history of Hyde, that this action did not violate the Hyde Amendment, and that Hyde applies only to the performance of the abortion itself, in violation of the plainly broad language that Congress used. Two of the first actions of a pro-life administration should be for HHS to withdraw the Medicaid guidance and any Section 1115 waivers issued thereunder, and for DOJ OLC to withdraw and disavow its interpretation of the Hyde Amendment. Prohibit Planned Parenthood from receiving Medicaid funds. During the 2020-2021 reporting period, Planned Parenthood performed more than 383,000 abortions. The national organization reported more than $133 million in excess revenue and more than $2.1 billion in net assets. During this same year, Planned Parenthood reports that its affiliates received more than $633 million in government funding and more than $579 million in private contributions. Planned Parenthood affiliates face accusations of waste, abuse, and potential fraud with taxpayer dollars, failure to report the sexual abuse of minor girls, and allegations of profiting from the sale of organs from aborted babies. Policymakers should end taxpayer funding of Planned Parenthood and all other abortion providers and redirect funding to health centers that provide real health care for women. The bulk of federal funding for Planned Parenthood comes through the Medicaid program. HHS should take two actions to limit this funding. 1. Issue guidance, re-emphasizing that states are free to defund Planned Parenthood in their state Medicaid plans. 2. Propose rulemaking to interpret the Medicaid statute to disqualify providers of elective abortion from the Medicaid program. Congress should pass the Protecting Life and Taxpayers Act, which would accomplish the goal of defunding abortion providers such as Planned Parenthood. CMS should resolve pending Section 1115 waivers from Idaho, South Carolina, and Tennessee, which, like Texas in January 2022, are seeking both to prohibit abortion providers from participating in state-run Medicaid programs and to work with other states to do the same. Abortion is not health care, and states should be free to devise and implement programs that prioritize qualified providers that are not entangled with the abortion industry. Withdraw Medicaid funds for states that require abortion insurance or that discriminate in violation of the Weldon Amendment. The Weldon Amendment declares that no HHS funding may go to a state or local government that discriminates against pro-life health entities or insurers. In blatant violation of this law, 7 states require abortion coverage in private health insurance plans, and HHS continues to fund those states. HHS under President Trump disallowed $200 million in Medicaid funding from California because of the state's flouting of the law, but the Biden administration restored it. HHS, CMS should withdraw appropriated funding up to and including 10% of Medicaid funds from states that require abortion insurance coverage. DOJ should commit to litigating the defense of those funding decisions promptly to the Supreme Court in order to maximize HHS's ability to withdraw funds from entities that violate the Weldon Amendment. Additionally, California has announced that it will discriminate against pharmacies that do not carry chemical abortion drugs outside of California. California's discrimination takes the form of cutting state contracts with such pharmacies and clearly violates the Weldon Amendment. The violation should likewise face the penalties discussed above. Rewrite the ACA abortion separate payment regulation. Section 1303 of Obamacare requires that insurers collect a separate payment for certain abortion coverage in qualified health plans that are approved to be sold on exchanges, and that they keep those separate payments in separate accounts that are used only to pay for elective abortion services. Neither the letter nor the spirit of the law was enforced under President Obama, and a Trump-era regulation sought to correct this problem. The Biden HHS rescinded this regulation to allow insurance companies, once again, contrary to the law, to collect combined payments for what are clearly required to be separate payments for elective abortion coverage. Separate does not mean together. HHS should reinstate a Trump administration regulation and enforce what the plain text of Section 1303 requires. That regulation should be further improved by requiring CMS to ensure that consumers pay truly separate charges for abortion coverage. Audit Hyde Amendment compliance. HHS should undertake a full audit to determine compliance or non-compliance with the Hyde Amendment and similar funding restrictions in HHS programs. This audit should include a full review of the Biden administration's post-Dobbs executive actions to promote abortion. It should also encompass a review of Medicaid managed care plans in pro-abortion states. Reverse distorted pro-abortion interpretations added to the Emergency Medical Treatment and Active Labor Act. The Emergency Medical Treatment and Active Labor Act, EMTALA, prohibits hospitals that receive Medicare funds from dumping emergency patients who cannot pay by sending them to other hospitals. It also mandates that hospitals stabilize pregnant women and explicitly protects unborn children. Hospitals or physicians found to be in violation of the statute could lose all of their federal health funding, Medicare, Medicaid, CHIP, and other funds, and face civil penalties of up to nearly $120,000. In July 2022, HHS CMS released guidance mandating that EMTALA-covered hospitals and the physicians who work there must perform abortions, to include completing chemical abortions even when the child might still be alive. The guidance also declared that EMTALA would protect physicians and hospitals that perform abortions in violation of state law if they deem those abortions necessary to stabilize the women's health. This novel interpretation of EMTALA is baseless. EMTALA requires no abortions, preempts no pro-life state laws, and explicitly requires stabilization of the unborn child. HHS should rescind the guidance and end CMS and state agency investigations into cases of alleged refusals to perform abortions. DOJ should agree to eliminate existing injunctions against pro-life states, withdraw its enforcement lawsuits, and in lawsuits against CMS on the guidance, agree to injunctions against CMS and withdraw appeals of injunctions. Reissue a stronger transgender national coverage determination. CMS should repromulgate its 2016 decision that CMS could not issue a national coverage determination, NCD, regarding gender reassignment surgery for Medicare beneficiaries. In doing so, CMS should acknowledge the growing body of evidence that such interventions are dangerous and acknowledge that there is insufficient scientific evidence to support such coverage in state plans. Enforce EMTALA. The undeniable reality of abortion is that it does not always result in a dead baby, and these born-alive babies are left to die. HHS should use EMTALA in Section 504 of the Rehabilitation Act, which prohibits disability discrimination, to investigate instances of infants born alive and left untreated in covered hospitals. CMS, OCR, and OIG should be required to follow through on these investigations with specific enforcement actions. HHS should revive a Trump administration. Proposed regulation. Special responsibilities of Medicare hospitals in emergency cases and discrimination on the basis of disability in critical health and human service programs or activities to achieve this end. In addition, Congress should pass the Born Alive Abortion Survivors Protection Act to require that proper medical care be given to infants who survive an abortion and to establish criminal consequences for practitioners who failed to provide such care. Permanently codify both the Hyde family of amendments and the protections provided by the Weldon Amendment. Congress can accomplish this through legislation such as the No Taxpayer Funding for Abortion and abortion insurance, Full Disclosure Act, Hyde, and the Conscience Protection Act, Weldon. Radical redefinition of sex. On August 4, 2022, HHS published a proposed rule entitled Non-Discrimination in Health Programs and Activities. This rule addresses non-discrimination provisions of the Affordable Care Act, known as Section 1557, which is enforced by the Office for Civil Rights and the Centers for Medicare and Medicaid Services. Section 1557 prohibits discrimination on the basis of race, color, national origin, age, disability, and sex in covered health programs or activities. Under the proposed rule, sex is redefined. Discrimination on the basis of sex includes, but is not limited to, discrimination on the basis of sex stereotypes, sex characteristics, including intersex traits, pregnancy or related conditions, sexual orientation, and gender identity. In other words, the department proposes to interpret Section 1557 as if it created special privileges for new classes of people defined in ways that are highly ideological and unscientific. The redefinition of sex to cover gender identity and sexual orientation and pregnancy to cover abortion should be reversed in all HHS and CMS programs, as was done under the Trump administration. This includes the Children's Health Insurance Program, CHIP. Low-income families who rely on CHIP should not be coerced, pressured, or otherwise encouraged to embrace this ideologically motivated sexualization of their children. However, while the Biden administration's Section 1557 regulation should be altered and corrected, the lactation room requirements added in the regulation should either be consistently included in any upcoming Section 1557 rulemaking or be proposed in a new individual rule. COVID-19 vaccination and mask requirements. Healthcare workers were praised for their self-sacrifice in caring for sick patients at the beginning of the COVID-19 pandemic, but then they were fired if they objected to receiving COVID-19 vaccines with or without complying with onerous masking requirements, and regardless of whether they already had the virus and had gained natural immunity. With the disease being endemic and constantly mutating, vaccines and universal masking in healthcare facilities do not have appreciable benefits in reducing COVID-19 transmission throughout the community. Moreover, More recent COVID strains pose fewer health risks than the earlier strains, and the pandemic has been declared to be at an end. CMS should announce non enforcement of the Biden administration's COVID 19 vaccination mandate on Medicaid and Medicare hospitals, revoke corresponding guidance and regulations, refrain from imposing general COVID 19 mask mandates on healthcare facilities or personnel, pay damages to all medical professionals who were dismissed directly because of the CMS vaccine mandate. Administration for Children and Families, ACF. TANF. The Temporary Assistance for Needy Families, TANF program, is a federal block grant that gives states significant flexibility to fund a broad array of programs aimed at helping low-income families break the cycle of poverty and achieve economic self-sufficiency. States use TANF to fund monthly cash assistance payments to low-income families with children, as well as a wide range of services that include work activities, work supports and supportive services, childcare, administration and systems, tax credits, pre-K Head Start, child welfare, and other services. The TANF program serves 1.8 million individuals. Since 1996, when the program was reformed, federal TANF outlays have been $16.5 billion. The state match is $14.9 billion, bringing the total state and federal TANF investment to $31.4 billion. The TANF statute requires that states engage 50% of single-parent families in work for at least 30 hours a week, 20 hours a week for single parents with children under age 6, though states have the option to waive the requirement for families with children under the age of 6, and most do. States also have 90% work requirements for two-parent families to engage in work for 35 hours per week. Because of the caseload reduction credit, states' work engagement targets are reduced if their assistance caseloads have fallen since 2005. As a result, 21 states had a work engagement target of 0% in 2017. Generally, states apply their work requirement only to beneficiaries receiving basic assistance, who account for 22.3% of TANF outlays. The Trump administration proposed a Supplemental Nutrition Assistance Program, SNAP rule, to increase program integrity and reduce fraud, waste, and abuse that would have prevented an individual from qualifying for SNAP simply because he or she received a pamphlet from the TANF program. This rule defined non-cash benefits as those that are worth at least $50 a month and received for at least 6 months. The tenets of this rule should be applied to the TANF program as well. This definitional change would apply the TANF work requirements to any non-cash benefit worth $50 a month and received for 6 consecutive months. To increase transparency, HHS should clarify how states, in their quarterly and annual reports, ought to track and audit the outcomes from how they spend TANF funds to meet the TANF program's 4 statutory purposes. Additionally, TANF priorities are not implemented in an equally weighted way. Marriage, healthy family formation, and delaying sex to prevent pregnancy are virtually ignored in terms of priorities, yet these goals can reverse the cycle of poverty in meaningful ways. CMS should require explicit measurement of these goals. Teen Pregnancy Prevention, TPP, and Personal Responsibility Education Program, PrEP. TPP is operated by the Office of Population Affairs in the Office of the Assistant Secretary for Health. PrEP is operated by the ACF Office of Planning, Research, and Evaluation. Both programs should ensure that there is better reporting of subgrantees and referral lists so that they do not promote abortion or high-risk sexual behavior among adolescents. CMS should ensure that sexual risk avoidance SRA proponents receive these grants and are given every opportunity to prove their effectiveness. SRA programs, both at ACF and at OASH, and both discretionary and mandatory, should be equal in funding and emphasis. Qualitative research should be conducted on both types of programs to ensure continuous improvement. In addition, certain provisions should be employed so that these programs do not serve as advocacy tools to promote sex, promote prostitution, or provide a funnel effect for abortion facilities and school field trips to clinics or for similar purposes. Parent involvement and parent-child communication should be encouraged and be a part of any funded project. Risk avoidance should be prioritized, and any program that submits a proposal that promotes risk rather than health should not be eligible for funding. Site visits should be revamped to ensure adherence to these optimal health metrics, and a cost analysis of programming as compared to students served should be a metric in funding, taking into account that in certain cases, intensive programs will serve fewer students and can have more positive results. These same parameters should apply to sex education programs at ACF. Any lists with approved curriculum or so-called evidence-based lists should be abolished. HHS should not create a monopoly of curriculum, adding to the profit of certain publishers. Furthermore, lists created in the past have given priority to sex promotion textbooks. HHS should create a list of criteria for evaluating the sort of curriculum that should be selected for any sex education grant programs, both at OASH and at ACF, with the aim of promoting optimal health and adhering to the legislative language of each program. Adoption reform. There are roughly 400,000 children across the nation on the waiting list for foster care and 100,000 awaiting adoptive families, and the opioid fentanyl crisis is putting more at risk every day. Unfortunately, many of the faith-based adoption agencies that serve these children are under threat from lawsuits, or else their licenses and contracts have been halted because they cannot, in good conscience, place children in every household due to their religious belief that a child should have a married mother and father. HHS, through ACF and the Assistant Secretary for Financial Resources, ASFR, should repeal the unnecessary 2016 regulation that imposes non-statutory sexual orientation and gender identity non-discrimination conditions on agency grants, and return to the policy of maximizing the options for placing vulnerable children in their forever homes. ACF and OCR should also survey their programs to consider whether additional waivers of HHS grant conditions, waivers the Biden administration revoked in 2021, are needed for faith-based agencies. Additionally, Congress should pass the Child Welfare Provider Inclusion Act to ensure that providers and organizations cannot be subjected to discrimination for providing adoption and foster care services based on their beliefs about marriage. Office of Refugee Resettlement, ORR. The Office of Refugee Resettlement should be moved to the Department of Homeland Security. Having health and welfare functions managed by HHS and border security functions managed by DHS has created intolerable failures in both. HHS and ORR have forgotten their original refugee resettlement mission and instead have provided a panoply of free programs that incentivize people to come to the U.S. illegally. Even more troubling, ORR has too often placed children into dangerous situations when releasing them into the country. Nearly all of HHS's care, custody, and placement of children is done through cooperative agreements with private agencies, many of which may have broken federal law by inducing or being accomplices in illegal immigration. Those arrangements could be handled far more effectively by DHS. Congress should reform the Trafficking Victims Protection Reauthorization Act to transfer all ORR duties for unaccompanied alien children to DHS and eliminate the Flores Settlement Agreement. Regardless of where ORR's functions reside, ORR staff and care providers should never be allowed to facilitate abortions for unaccompanied children in its custody, including by transporting minors across state lines from pro-life states to abortion-friendly states. Pregnant, unaccompanied girls in ORR custody should be treated with dignity, not trafficked across state lines to be victimized by the abortion industry. ORR should withdraw its policy of allowing elective abortions for children in ORR care and issue a new policy of instructing care providers not to allow girls to be transported for elective abortions. HHS OGC and the White House should insist that DOJ fight to defend that policy up to the U.S. Supreme Court in light of Dobbs. Office of Child Support Enforcement, OCSE. Congress established aid to families with dependent children in 1935 to assist single-parent families who were suffering financially from the loss of a breadwinning husband and father. Within 2 decades, however, the majority of families receiving aid were dependent because of paternal abandonment rather than death. Today, nearly a third of America's children live without a father present in the home, and a fourth of them are enrolled to receive child support. The glaring issue in child support enforcement today is a non-resident father's ability to provide full or consistent child support payments. The literature reflects this divide as fathers have been categorized as deadbeat dads, then as dead broke dads, and now as disconnected dads who do not commit to the mother and child. Child support in the United States should strengthen marriage as the norm, restore broken homes, and encourage unmarried couples to commit to marriage. Child support tax credit. National or state guidelines and tax laws should be updated to ensure that non-resident parents with child support orders can receive a non-dependent child support tax credit. Single filers of up to $41,756 and married or joint filers of up to $47,746 would be eligible for a child support tax credit similar to the current earned income tax credit. Filers could receive a maximum of $538 in annual returns for one child and a maximum of $3,584 in annual returns for 2 or more children, based on a credit rate of 34%. A child support tax credit would use the low-income, non-resident parent's own earned income and history of employment to assist them further in the task of caring for their children. The key to this policy is that it empowers fathers with their own resources and money rather than creating another government assistance program or a fully refundable credit devoid of the father's own monetary efforts. This way, the non-resident father's role as financial provider and relational figure is affirmed, and much-needed financial resources are given to the children. Visitation. Visitation is key to revitalizing child support and increasing payment frequency. The most effective way to lower a non-resident parent's monthly child support order is to spend more court-accounted for time with the child. For example, Texas combined its child support court with its visitation court to ensure that resident and non-resident parents received state-mandated financial support orders and enforceable visitation orders. Child support payment and interactive smartphone application. each state should be induced to implement a high-tech, easy-to-use application to centralize child support payments. As with Venmo or Cash App, non-resident parents would link their bank accounts and provide one-click monthly payments or contribute incrementally throughout the month while tracking how much is due. Additionally, the non-resident parents could track informal gifts from money, groceries, clothes, sports gear, and more through the app. This would address one of the main issues within current child support payment systems. Non-resident parents claim that they are spending much of their own money to provide for children outside of their monthly payments, and resident parents claim that they spend little and neglect their official child support orders. Currently, only the latter claim can be tracked reliably. This process would enable non-resident parents to track the amount of informal support they provide and the reason for it, while ensuring that the resident parent acknowledges and accepts the contribution. Healthy Marriage and Relationship Education HMRE program. The HMRE program is part of the ACF Office of Family Assistance. The following policies should be implemented. Utilize HMRE funding or grants to provide state-level high school education resources and curriculum on healthy marriages, sexual risk avoidance, and healthy relationships. Early interventions and prevention are much more cost-effective than our efforts to reach people already in broken relationships. Allow child welfare funding to be used for marriage and relationship education. Congress should adopt the following recommendation from a report issued by members of Congress's Joint Economic Committee. Children are far more likely to experience abuse when they are raised outside of their married parent family. Title VI of the Child Abuse Prevention and Treatment Act provides grants to communities for the purpose of preventing child abuse and neglect, and one of the stated purposes for which the grants can be used is for efforts to increase family stability. However, Congress could change the law to make it clear that Title II funding can be used for healthy marriage and relationship education. Funding provided under Title B of the Social Security Act, which provides grants to states for foster care and adoption services, can also be used for promoting healthy marriage. States should consider using some of their Title IVB funding for providing healthy marriage and relationship education for families at risk of having their children placed in foster care. Provide educational information on healthy marriage and relationships at Title X family planning clinics. HHS should require clinics it funds under Title X family planning to provide information to customers about the importance of marriage to family and personal well-being, and refer them to available federal, state, and nonprofit marriage resources. Ensure proper assessments with enough time to assess HMRE programs. Although some widely available assessments of HMRE programs report poor outcomes, many of these assessments either utilized a poor methodology or tried to measure program success prematurely. Recent assessments have shown increasing effectiveness and positive community-level marital outcomes. The HMRE program should receive a fair and realistic assessment. Additionally, the positive role of faith-based programs should be protected and prioritized so that these programs do not receive undue scrutiny or pressure to conform to non-religious definitions of marriage and family, as put forward by the recently enacted Respect for Marriage Act. Protect faith-based grant recipients from religious liberty violations and maintain a biblically based, social science reinforced definition of marriage and family. Social science reports that assess the objective outcomes for children raised in homes aside from a heterosexual, intact marriage are clear. All other family forms involve higher levels of instability. The average length of same sex marriages is half that of heterosexual marriages. Financial stress or poverty, and poor behavioral, psychological, or educational outcomes. For the sake of child well being, programs should affirm that children require and deserve both the love and nurturing of a mother and the play and protection of a father. Despite recent congressional bills like the Respect for Marriage Act that redefine marriage to be the union between any two individuals, HMRE program grants should be available to faith-based recipients who affirm that marriage is between not just any two adults, but one man and one unrelated woman. Healthy Marriage and Responsible Fatherhood, HMRF program. This program is located within the ACF Office of Family Assistance. Its goal, like that of the HMRE program, is to provide marriage and parenting guidance for low-income fathers. This includes fatherhood and marriage training, curriculum, and subsequent research. Implement a pro-fatherhood messaging campaign. With nearly 41% of children born without a married father in the home, and nearly 69% among Black Americans, the fatherhood problem is clear. Similar to Florida Governor Ron DeSantis' 2022 fatherhood bill, HMRF funds should be used to support national messaging campaigns that affirm the role fathers play in the lives of their children, that recognize the financial hardships the fathers themselves face, and that seek to provide relationship education to fathers who were raised without a father in the home. Fund effective HMRF state programs. Grant allocations should protect and prioritize faith-based programs that incorporate local churches and mentorship programs or increase social capital through multi-layered community support, including, for example, job training and social events. Programs should affirm and teach fathers based on a biological and sociological understanding of what it means to be a father, not a gender-neutral parent, from social science, psychology, personal testimonies, etc. Administration on Children, Youth, and Families, ACF. Allocate funding to strategy programs promoting father involvement or terminate parental rights quickly. ACYF is currently considering different programs to encourage parents, especially fathers, to engage with their children in foster care. While these program ideas and initiatives are still in the early planning stages, promoting responsible parenthood to reintegrate children or at least keep a consistent male figure in the minor's life is crucial. At the same time, in cases where the father or mother does not make a sincere or serious effort to be involved in the child's upbringing, termination of parental rights for children in foster care should be swift. Office of Head Start, OHS. Eliminate the Head Start program. Head Start, originally established and funded to support low-income families, is fraught with scandal and abuse. With a budget of more than $11 billion, the program should function to protect and educate minors. Sadly, it has done exactly the opposite. Research has demonstrated that federal Head Start centers, which provide preschool care to children from low-income families, have little or no long-term academic value for children. Given its unaddressed crisis of rampant abuse and lack of positive outcomes, this program should be eliminated along with the entire OHS. At the very least, the program's COVID-19 vaccine and mask requirements should be rescinded. Administration for Community Living, ACL. Support palliative care. Physician-assisted suicide, PAS, is legal in 10 states and the District of Columbia. Legalizing PAS is a grave mistake that endangers the weak and vulnerable, corrupts the practice of medicine and the doctor-patient relationship, compromises the family and intergenerational commitments, and betrays human dignity and equality before the law. Instead of embracing PAS, policymakers should focus on the benefits of palliative care, which works to improve a patient's quality of life by alleviating pain and other distressing symptoms of a serious illness. HHS ACL should survey their programs to ensure that they are supporting vulnerable persons of age or disability and are not facilitating or encouraging participation in PAS. Readdress the national strategy to support family caregivers. While in theory, the strategy aims to support family members with duties to care for older family members, the plan is overly focused on racial and LGBTQ plus equity. The strategy should be examined to establish an efficient plan to support caregivers and their families. There should also be a review of its COVID-19 policies. Health Resources and Services Administration, HRSA. Congress should allow CMS to use the 340B data that HRSA collects rather than having CMS conduct its own survey, especially in view of the U.S. Supreme Court's American Hospital Association Visa Becerra decision. The legislation should also create penalties for those who do not respond to HRSA's data collection. Legally define the locus of service as where the provider is located during the telehealth visit rather than where the patient is. With such a definition, states could continue to reserve their powers to establish the standards for licensure and scope of practice. The providers could ensure continuity and consistency of care no matter where their patients might move while maintaining the licenses that make the most sense for them. Americans are far more mobile and technologically advanced today than they were when most healthcare laws were written. Telehealth has become increasingly important, particularly during the height of the COVID-19 pandemic. It also has great potential in rural and other areas where there are shortages of healthcare providers. HRSA's Office for the Advancement of Telehealth includes a program known as the Licensure Portability Grant Program, which bolsters state efforts to reform licensing laws to maximize telehealth flexibility. HRSA does not have the authority through this office to dictate licensure laws. That power has typically been reserved to the states. However, telehealth across state lines, when permitted, is interstate commerce, which can be regulated by the federal government according to the Constitution. Restore Trump religious and moral exemptions to the contraceptive mandate. HHS should rescind, if finalized, the regulation titled Coverage of Certain Preventive Services under the Affordable Care Act, proposed jointly by HHS, Treasury, and Labor. This rule proposes to amend Trump-era final rules regarding religious and moral exemptions and accommodations for coverage of certain preventive services under the ACA. Preventive services include contraception, and it appears the proposed rule would change the existing regulations for religious and moral exemptions to the ACA's contraception mandate. There is no need for further rulemaking that curtails existing exemptions and accommodations. Require HRSA to use rulemaking to update the Women's Preventive Services Mandate. The contraceptive mandate issued under Obamacare has been the source of years of egregious attacks on many Americans' religious and moral beliefs. The mandate was issued as part of the Women's Preventive Services Guidelines, which were issued without any rulemaking that involved public notice and an opportunity to comment. Instead, HRSA issued and changed the mandate by simply posting changes to its website. HRSA also started off not requiring coverage of fertility awareness-based methods of family planning, then requiring them, and then removing the requirement without notifying the public. A federal judge recently ruled that this failure to undergo notice and comment in issuing the mandate is unlawful. HRSA should be required to repromulgate any women's preventive services mandates through the notice and comment process that is compliant with the Administrative Procedures Act. Moreover, since the Obama administration, HRSA entered into long-term contracts with the pro-abortion American College of Obstetricians and Gynecologists, ACOG, and related entities to serve as an exclusive advisor with respect to the content of this mandate. HRSA has used this arrangement to ignore comments that members of the public were sometimes able to submit in the process, and ACOG has abused its position to attack HHS's allowance of religious and moral exemptions to the contraceptive mandate. HHS should rescind these contracts and establish an advisory committee that is compliant with the Federal Advisory Committee Act and has members that are committed to women's preventive services and are not pro-abortion ideologues. Expand inclusion of fertility awareness-based methods and supplies to family planning in the Women's Preventive Services Mandate. The ACA requires coverage of and prevents insurance plans from imposing any cost-sharing requirements on women who obtain preventive care and screenings as defined by HRSA. In 2016, HHS included instruction in fertility awareness-based methods as part of this requirement. However, in December 2021, HHS removed that language from its list without using the notice and comment process or giving any rationale, both of which are mandated by the Administrative Procedures Act. In August 2022, a federal court blocked this attempt to eliminate health insurance coverage for fertility awareness-based methods of family planning from requirements that cover at least 58 million women, and the judge made his ruling permanent in December 2022. HRSA should promulgate regulations consistent with this order. HHS should more thoroughly ensure that fertility awareness-based methods of family planning are part of women's preventive services under the ACA. FABMs often involve costs for materials and supplies, and HHS should make clear that coverage of those items is also required. FABMs are highly effective and allow women to make family planning choices in a manner that meets their needs and reflects their values. Eliminate men's preventive services from the Women's Preventive Services Mandate. In December 2021, RSA updated its Women's Preventive Services Guidelines to include male condoms after claiming for years that it had no authority to do so because Congress explicitly limited the mandate to women's preventive care and screenings. HRSA should not incorporate exclusively male contraceptive methods into guidelines that specify they encompass only women's services. Eliminate the week after pill from the contraceptive mandate as a potential abortifacient. One of the emergency contraceptives covered under the HRSA Preventive Services Guidelines is Ella, ulipristal acetate. Like its close cousin, the abortion pill mifepristone, Ella is a progesterone blocker and can prevent a recently fertilized embryo from implanting in a woman's uterus. HRSA should eliminate this potential abortifacient from the contraceptive mandate. Withdraw Ryan White guidance allowing funds to pay for cross-sex transition support. HRSA should withdraw all guidance encouraging Ryan White HIV/AIDS program service providers to provide controversial gender transition procedures or gender-affirming care, which cause irreversible physical and mental harm to those who receive them. Ensure that training for medical professionals, doctors, nurses, etc., and doulas is not being used for abortion training. HHS should ensure that training programs for medical professionals, including doctors, nurses, and doulas, are in full compliance with restrictions on abortion funding and conscience protection laws. In addition, HHS should 1. Investigate state medical school compliance with the Coates-Snow Amendment, which prohibits discrimination against healthcare entities that do not provide or undergo training for abortion. 2. Ensure that the Accreditation Council for Graduate Medical Education, ACGME, complies with all relevant conscience statutes and regulations, and that states have taken the affirmative steps, for example, by issuing regulations, to assure compliance with Coates-Snow. 3. Communicate to medical schools that any abortion-related training must be on an opt-in rather than opt-out basis. 4. Require states that receive HHS funds to issue regulations or enter into arrangements with accrediting bodies to comply with the Coates-Snow Amendment's prohibition of mandatory abortion training by individuals or institutions. The Coates-Snow Amendment specifically requires such state regulations or arrangements. Prioritize funding for home-based child care, not universal daycare. As HRSA's Early Childhood Health page outlines, currently only about half of U.S. preschoolers are on track with their development and ready for school. And more than 1 in 4 of children, 28%, who experience abuse or neglect are under 3 years old. Concurrently, children who spend significant time in daycare experience higher rates of anxiety, depression, and neglect, as well as poor educational and developmental outcomes. Instead of providing universal daycare, funding should go to parents, either to offset the cost of staying home with a child or to pay for familial in-home child care. Provide education and resources on early childhood health. By partnering with new organizations like the Center on Child and Family Poverty, HRSA should provide resources and information on the importance of the mother-child relationship in child well-being. This should include relationship education curricula that equip mothers and caregivers to connect with and improve their understanding of their infants, toddlers, and young children. Maternal and child health. Currently, the HRSA Maternal and Child Health Program is collecting data on the benefits of doulas in improving the health, safety, and emotional well-being of mothers at birth. Doulas provide a patient-focused non-medical support system for single or married mothers that decreases the overall cesarean rate by 50%, the length of labor by 25%, the use of oxytocin by 40%, and requests for an epidural by 60%. Doulas often use the power of touch and massage to reduce stress and anxiety during labor. Given concerns about maternal mortality or postpartum depression that is worsened by poor birth experiences, doulas should be an active option for all women, whether they are giving birth in a traditional hospital, through midwifery, or at home. Additionally, since most doulas services are not covered by traditional insurance programs, the Maternal and Child Health Program should work to provide funding for low-income mothers. Indian Health Service, IHS. The Indian Health Service serves our American Indian and Alaska Native populations. Reforms are needed to improve America's ability to deliver on its promises to these important populations and must take account of cultural preferences and lifestyles, limitations due to geography, such as challenging terrain, and limited internet access. For example, contacting individuals within some of these communities and tribes during the COVID-19 pandemic proved to be difficult because many had transient addresses and unreliable cell service. During the transition to the Biden administration, IHS abandoned tribes as their sources of COVID-19 tests and vaccine supplies disappeared. It is important to guard against such situations in order to preserve these tribes' access to health resources during public health emergencies, PHEs. Even before the pandemic, services available to these populations through federal resources and personnel, such as vision care, were often scarce or non-existent. Patients in these populations should be empowered to rely on alternatives to IHS through better access to private healthcare providers. Exploring positive reforms contained in the VA Mission Act could reveal similar opportunities for increased options and access for American Indians and Alaska Natives. Rural health. A growing concern is the decreasing access to healthcare services for Americans living in rural, less populated areas. Many find themselves in regions that were not previously as rural as industries move away, taking with them economic prosperity and often medical providers. Others are in essential professions such as farming that by nature necessitate living in regions with fewer city accommodations and economic opportunities. Seeking space for one's family and cultivating the land are valued goals that are deeply rooted in America's fabric. Both Congress and an administration must continually keep in mind how healthcare policies uniquely affect these regions because their market trends and populations are different from those of more populous regions. Often, rural patients face an hour's drive to the nearest medical provider or facility or have limited or no internet access, which restricts their access to telehealth services, especially video visits. To improve its healthcare policies that affect rural regions, HHS should reduce the regulatory burden and unleash private innovation that can discover solutions to unique local needs. Implement or encourage policies that increase the supply of healthcare providers, such as increased telehealth access and interstate licensure, a historically state matter, including for volunteers wishing to provide temporary charitable services across state lines. Encourage flexibility in modes of healthcare delivery, including less expensive alternatives to hospitals and telehealth independent of expensive air ambulances. Office of the Secretary. The Secretary of Health and Human Services and the Office of the Secretary necessarily set the tone for the entire department. The Secretary is the most accountable individual within HHS and, along with his or her immediate staff, should therefore be responsible for setting the policies that govern the department's operations instead of allowing the operational divisions to assume the leading role in policymaking, thereby diffusing responsibility. Practical reforms to enhance the Secretary's accountability should include the following. Restrict HHS's ability to declare indefinite public health emergencies, PHEs. Currently, HHS is merely required to notify Congress of such a declaration within 48 hours. Congress should establish a set time frame for any PHE, placing on the Secretary the burden of proof as to why an extension of the PHE is necessary. Reinstate the HHS sunset, securing updated and necessary statutory evaluations timely, rule. Congress should codify the now reversed Trump administration rule that required all HHS agencies to review regulations retrospectively and publish results. Without such a review, regulations expire. Investigate, expose, and remediate any instances in which HHS violated people's rights. By the 1. colluding with big tech to censor dissenting opinions during COVID. 2. Colluding with abortion advocates and LGBT advocates to violate conscience protection laws and the Hyde Amendment. The Life Agenda. The Office of the Secretary should eliminate the HHS Reproductive Healthcare Access Task Force and install a pro-life task force to ensure that all of the department's divisions seek to use their authority to promote the life and health of women and their unborn children. Additionally, HHS should return to being known as the Department of Life by explicitly rejecting the notion that abortion is health care and by restoring its mission statement under the strategic plan and elsewhere to include furthering the health and well-being of all Americans from conception to natural death. The next administration should create a dedicated special representative for domestic women's health. In the Trump administration, there was a special representative for global women's health that focused on international issues, but this position lacked authority to be the lead on international policies because of overlapping issues with the U.S. Department of State and USAID, and at times a lack of clarity as to the lead point of contact and policy decisions at the White House. The new special representative would serve as the lead on all matters of federal domestic policy development related to life and family, with support from the DPC for implementation and coordination among agencies. In the post-Dobbs era, advancing support for mothers will include coordination among agencies outside of HHS, and the special representative would provide a clear focal point for all issues related to protecting life and serving families. The Family Agenda. The Secretary's anti-discrimination policy statements should never conflate sex with gender identity or sexual orientation. Rather, the Secretary should proudly state that men and women are biological realities that are crucial to the advancement of life sciences and medical care, and that married men and women are the ideal natural family structure because all children have a right to be raised by the men and women who conceived them. Office of the Assistant Secretary for Health, OASH. Office of the Surgeon General, OSG. The Assistant Secretary for Health, ASH, is the 4-star Admiral for the United States Public Health Service Commission Corps, USPHS, and the Surgeon General, SG, is the 3-star Admiral. The ASH is tasked with overseeing not only the USPHS, but also 10 regional health offices, multiple presidential and secretarial advisory committees, and other offices such as the Offices of Minority Health, Women's Health, and Population Affairs. The Secretary can further expand the ASH's responsibilities, for example, by designating the ASH as liaison to the CDC. The SG officially oversees the daily operations of the USPHS, although those are actually under the control of the director of the USPHS Commission Corps headquarters. The SG also issues information to the public, Surgeon General's advisories, calls to action, and reports, serving in effect as a key public health spokesperson for the federal government. USPHS officers are assigned to various agencies such as the CDC, NIH, and Bureau of Prisons. Their organizational structure is similar in some respects to the National Guard's, and their salaries are paid primarily by the agencies to which they are assigned, which serves to limit USPHS appropriations. USPHS officers can be deployed on missions to respond to domestic or international crises, for example, a hurricane in Florida or an Ebola outbreak in Africa, at any time. The USPHS should be restructured to make it more like its sister uniformed services, with a more streamlined chain of command and corresponding appropriations to ensure efficiency and clarity of mission. Its core mission should be refocused to emphasize prompt, responsive deployments that meet specific criteria and are less dependent on the various agencies to which the officers are assigned. Fulfillment of specific tasks should not be duplicated by non-uniformed civil servants and USPHS officers, and any roles that can be filled by civilians should be filled by them. The ASH and SG positions should be combined into one four-star position with the rank, responsibilities, and authority of the ASH retained, but with the title of Surgeon General and some of the SG's communications responsibilities, which would include disseminating other HHS messages and sharing general medical advice without legal weight. The holder of this consolidated position, which should be filled by a healthcare provider, would be better positioned to ensure that the USPHS is properly focused and deployed. With such reforms, the supporting office, previously the OASH and OSG, would be better equipped than other HHS offices or agencies to reduce silos and consolidate or eliminate duplicative functions. Congress should consider legislation that would require this office to take such actions, or at least make such recommendations to the Secretary. Such legislation would require a thorough analysis of the various legal authorities impacting the department's current organizational structure. The position previously known as the Principal Deputy Assistant Secretary for Health should be combined with and have the title of Deputy Surgeon General and become a three-star position with operational control, including financial and deployment decisions. The director of the headquarters should be responsible for implementing the decisions of the Deputy Surgeon General. Promoting life and family. In dealing with sexually transmitted diseases and unwanted pregnancies, the OASH should focus on root cause analysis with a focus on strengthening marriage and sexual risk avoidance. Strong leadership is needed in the Office of Science and Medicine to drive investigative review of literature for a variety of issues, including the effect of abortion on prematurity and breast cancer, lack of evidence for so-called gender-affirming care, and physical and emotional damage following cross-sex treatments, especially on children. The OASH should withdraw all recommendations of and support for cross-sex medical interventions and gender-affirming care. Title X. The Title X Family Planning Program should be reframed with a focus on better education around fertility awareness and holistic family planning, and a Deputy Assistant Secretary for Population Affairs that understands the program and is able to work within its legislative framework, ideally an MD. In addition, the Office of Population Affairs should eliminate religious discrimination in grant selections and guarantee the right of conscience and religious freedom of healthcare workers and participants in the Title X program. In 2021, HHS reversed a Trump administration regulation that required grantees to maintain strict physical and financial separation between Title X activity and abortion-related activity. Under the Biden administration's regulation, Title X activity can be conducted alongside abortion activity without strict physical and financial separation. The regulation also requires grantees to refer for abortions despite sincere moral or religious objections. This effectively bans otherwise qualified pro-life grantees from participating in the program. HHS should rescind the Biden administration's regulation and reinstate the Trump administration regulation for the program. It should also do this quickly. The Biden administration completed its regulatory process and issued a final rule in less than 9 months, and expand the potential grantee population beyond abortion providers like Planned Parenthood. Congress should complement these efforts by passing legislation such as the Title X Abortion Provider Prohibition Act, which would prohibit family planning grants from going to entities that perform abortions or provide funding to other entities that perform abortions. This would help to protect the integrity of the Title X program even under an abortion friendly administration. Administration for Strategic Preparedness and Response, ASPR. ASPR versus FEMA. When the President declares a national emergency, per the Stafford Act, related to a public health emergency declared by the HHS Secretary, FEMA is activated and controls instead of HHS ASPR. While this arrangement has some benefits because of FEMA's unique logistical capabilities, the arrangement should be reviewed, especially considering the COVID-19 pandemic, for improvements in efficiency according to expertise and available resources, reduce confusion for ASPR and among HHS agencies, and avoidance of duplicated efforts among agencies and personnel. Strategic National Stockpile. The President should invoke the Defense Production Act, which is a form of temporary takeover of private enterprises, only in the gravest circumstances. The Strategic National Stockpile, SNS, should be reformed to consider the potential supply chain disruptions of pandemics or global conflicts. Also, during the COVID pandemic, many states received ventilators from the SNS and hoarded them in places where a rush of COVID patients needing ventilators never materialized. The SNS should clarify its mission as supplier of last resort to the federal government, state governments, or first responders and key medical staff, and should not portray itself as serving the public as a whole. Office of General Counsel, OGC. The Office of General Counsel is essential to ensuring that HHS is operating within the bounds of its numerous governing statutes. However, legal caution can outweigh practical necessity and often slows processes and decisions when time is of the essence. Such problems were evident both before and during the COVID-19 pandemic. Internal processes should be reformed to streamline necessary legal determinations during crises, and general processes should be reviewed for efficiency. OGC should also rescind its PrEP Act. Liability Memo. OGC issued a PrEP Act. Liability Memo that suspended application of civil rights and other laws in the context of the administration of covered countermeasures during the pandemic. It should be rescinded as contrary to law. Rescind efforts to curtail OCR authority over conscience and religious freedom. All OGC memos and Federal Register notices of organization or delegations of authority moving any OCR conscience and religious freedom enforcement to OGC, including RFRA, should be rescinded, and independent authority over these matters should be restored to OCR. Encourage DOJ to repeal OLC memos, allowing abortion funding, despite hide-in memos allowing federal enclave immunity to perform abortions despite the Assimilative Crimes Act. Rescind legal analysis that authorized HHS to impose a moratorium on rental evictions during COVID. Rescind the OGC legal analysis saying that the injunction in Bowen v. American Hospital Association prevents any proposed HHS regulations or enforcement actions concerning the denial of care to newborn infants with disabilities by covered healthcare entities without or against parental consent. Rescind the legal analysis supporting the Biden administration's decision to dismiss the University of Vermont Medical Center case dealing with the forced participation of a nurse in abortion in violation of law. Recent the legal analysis restoring $200 million in Medicaid funds to California after having been found to be in violation of the Weldon Amendment by OCR. Office of Global Affairs, OGA. The director of the Office of Global Affairs should have the title of Assistant Secretary so that he or she can adequately represent HES and the Secretary and serve as the lead on global health diplomacy for the government. The designation director is not understood to indicate the leadership role that this position holds in the international arena. In addition, all divisions that work on international health efforts should be responsive to requests and direction from the Assistant Secretary with coordination for all health diplomacy emanating from OGA. OGA should have a clear and consistent voice for the administration's pro-life and pro-family priorities in all international engagements. OGA should hold oversight authority for implementation of the Mexico City policy throughout all divisions. Every effort should be made to locate all OGA staff in the same building for better oversight and communication. Health attachés in various global locations should be trained in the administration's policies with clear expectations communicated and with accountability, including replacement when their conduct and advocacy are contrary to administration policies and programmatic priorities. Office for Civil Rights, OCR. Conscience enforcement. Existing statutes that protect rights of conscience, such as the Church, Coate Snow, and Weldon Amendments, do not explicitly provide a private right of action that would allow victims to seek legal redress in court. At the same time, when it continues to fund governmental and private entities that violate these laws, HHS is spending taxpayer funds unlawfully. Under liberal administrations, OCR has amassed a poor record of devoting resources to conscience and religious freedom enforcement, and is often complicit in approving or looking the other way at the administration's own attacks on religious liberty. Congress should pass the Conscience Protection Act so that victims can pursue redress through courts without having to depend exclusively on OCR. In addition, OCR should return to Trump administration policies that initiated robust enforcement of these conscience laws. It should restore and fully fund the Office of the Deputy Director for the Conscience and Religious Freedom Division, CRFD, and ensure that it has the necessary delegations from the Secretary to enforce these laws. The Secretary should give adequate delegations to OCR to pursue enforcement of conscience laws, including RFRA, and require all HHS components that provide funding or grants to cooperate with OCR CRFD investigations. The Secretary, the Deputy Secretary, and principals in other HHS divisions should endorse the remedial measures recommended by OCR CRFD and limit territorial objections and slow down attempts by other divisional officials, including OGC. HHS should withdraw funding from any violating entities that refuse to correct their behavior, and OCR CRFD should work with ASFR to ensure that all grant announcements and instruments inform grantees and applicants of their obligations to comply with federal healthcare conscience laws, specifically as a condition of obtaining or maintaining their funding. A draft OCR RFRA and religious freedom rule from the Trump administration should be issued and finalized. These regulations would provide a clear process for OCR's enforcement in coordination with other HHS divisions and existing HHS grants regulations. HHS should reestablish waivers for state and child welfare agencies for religious exemptions, especially for faith based adoption and foster care agencies. It should also rescind subjective, case by case evaluations for religious and faith based organizations that request religious exemptions. These case by case determinations are currently coordinated with ACF and OCR. The recommended waivers should be granted to all states and agencies that request them, and OCR memos finding that RFRA would be violated if the waivers are not granted should be restored. HHS should restore OCR authority to review requests for and render opinions on the application of RFRA to requests for religious accommodation of people, families, and doctors who cannot in good conscience take or administer vaccines, including those made or tested with aborted fetal cell lines. HHS should restore Section 1557, Section 504, and other OCR regulations and fix guidance documents. In 2020, the Trump administration's OCR published regulations under Section 1557 of the Affordable Care Act that restored the agency's enforcement of that law to the limits of its statutory text, deferred to the ACA's widespread use of a binary biological conception of sex discrimination, and specified that the regulation must comply with the religious exemption and abortion neutrality clauses in Title IX, from which it is derived, as well as the Religious Freedom Restoration Act and other laws. Courts blocked core provisions of that rule from going into effect. In 2022, the Biden administration proposed to reinstate a rule contradicting the scope of the statute and imposing non-discrimination on the basis of sexual orientation and gender identity. It is expected that this rule will be finalized in 2023, even though several courts have issued rulings against the interpretation on which it is based. OCR should return its enforcement of sex discrimination to the statutory framework of Section 1557 and Title IX. Specifically, it should 1. Remove all guidance issued under the Biden administration concerning sexual orientation and gender identity under Section 1557, particularly the May 2021 announcement of enforcement and March 2022 statement threatening states that protect minors from genital mutilation. 2. Issue a general statement of policy specifying that it will not enforce any prohibition on sexual orientation and gender identity discrimination in the Section 1557 regulation, and that it will prioritize compliance with the First Amendment, RFRA, and federal conscience laws in any case implicating those claims. DOJ should commit to defending these actions aggressively against inevitable court challenges, including under cases such as Heckler v. Cheney. 3. Issue a proposed rule to restore the Trump regulations under Section 1557, explicitly interpreting the law not to include sexual orientation and gender identity discrimination based on the textual approach to male and female biology taken by Congress in the ACA, the need to recognize biological distinctions as part of the sound practice of health care, and the need to ensure protections of medical judgment and conscience. DOJ should agree to defend this rule to the Supreme Court if necessary. 4. Issue a general statement of policy announcing that it plans to enforce Section 1557 discrimination bans by refocusing on serious cases of race, sex, and disability discrimination. In particular, OCR should highlight its 2019 investigation and voluntary resolution agreement with Michigan State University based on the sexual abuse of gymnasts by Larry Nassar. OCR should also coordinate with the Department of Education on a public education and civil rights enforcement campaign to ensure that female college athletes who become pregnant are no longer pressured to obtain abortions. Pursue race discrimination claims against entities that adopt or impose racially discriminatory policies, such as those based on critical race theory, and announce its intention to enforce disability rights laws to protect children born prematurely, children with disabilities, and children born alive after abortions. 5. Issue and finalize the Trump era draft disability rights regulations concerning crisis standards of care and use of quality of life. Adjusted years, QLEs, and reissue and finalize a disability regulation withdrawn by the Biden administration that prohibited discriminatory application of assisted suicide and denial of life-saving treatments for disabled newborns. OCR should withdraw its pharmacy abortion mandate guidance. OCR should withdraw its obligations under federal civil rights laws to ensure access to comprehensive reproductive health care services guidance for retail pharmacies, which purports to address non-discrimination obligations of pharmacies under federal civil rights laws, and in fact, orders them to stock and dispense first trimester abortion drugs. The guidance invents this so-called requirement and fails to acknowledge that pharmacies and pharmacists have the right not to participate in abortions, including pill-induced abortions, if doing so would violate their sincere moral or religious objections. Moreover, no federal civil rights laws preempt state pro-life statutes. OCR should withdraw its Health Insurance Portability and Accountability Act, HIPAA, guidance on abortion. OCR should withdraw its June 2022 guidance that purports to address patient privacy concerns following the Dobbs decision, but is actually a politicized statement in favor of abortion and against Dobbs. HIPAA covers patients in the womb, but this guidance treats them as non-persons contrary to law. The guidance is unnecessary and contributes to ideologically motivated fear-mongering about abortion after Dobbs.